is week 1, voice over PowerPoint for the perioperative care. As we proceed with this module, we will start with the preoperative. In the next slideshow, we will look at intraoperative, and then the slideshow after that, we will look at postoperative. There are specific concerns in each of these sections. However, there is going to be some overlap. So if it does seem a little repetitive, please still pay attention. There is, some distinct differences that you will want to know. The operative experience is broken into 3 phases: preoperative, intraoperative, and postoperative. These 3 phases are known as the perioperative or the surgical services. Although each of these phases possess unique nursing needs, the preoperative phase is a patient's first experience with surgical services. The preoperative phase commences when the decision for surgery is made and ends when the patient is transferred to the surgical suite. There are 3 primary types of surgical procedures: emergent, urgent, or elective. Emergent surgeries are surgeries that must be done immediately to save a patient's life, limb, or the ability to function. Urgent surgeries are surgeries that must be done within 24 to 48 hours to prevent permanent injury to the patient or death. Elective surgeries are surgeries that may be necessary but can be planned around the patient's and surgeon's schedule. Most surgeries done in the United States are elective surgeries. So a question to ask: emergent surgery takes place as soon as medically possible. What are some reasons we wouldn't rush into an emergent surgery? Think on that, and we'll discuss it in class. Priority when it comes to surgeries is safety. This requires teamwork and interprofessional communication. We have some governing organizations. These are these 3 organizations that oversee patient safety for the perioperative area. Those 3 organizations are the Joint Commission, the World Health Organization, and the Association of Perioperative Registered Nurses. Annually, they publish a national patient safety goal based on emergent patient safety issues. The goals are going to focus on problems in healthcare and how to solve them. While all these goals are important, there are a few that are very specific to surgical services. Those goals, specific to surgery, fall under the Prevent Mistakes in Surgery section. These 3 goals in this section make up the Joint Commission's Universal Protocol for Preventing Wrong Site, Wrong Procedure, and Wrong Person Surgery. Wrong patient, wrong site, wrong procedure events are relatively rare, preventable events that can lead to catastrophic harm to patients. The Joint Commission's Universal Protocol are well-established procedures and processes that can help prevent these types of events from occurring. The Universal Protocol is made up of 3 different sections. We have a pre-procedure verification process, which is done in the pre-op area. We have the procedural site marking done in the pre-operative area. And we have the procedural timeout, which is done in the OR. Pre-procedure verification process includes several items. We want to make sure that they're having the correct procedure for the correct patient on the correct site. We want to involve our patient in the verification process because hopefully they know that it's, the left arm versus the right arm that needs the surgery, and they should be able to point it out. We want standardized lists. We need items that must be available for our procedure. We need relevant documentation. We need our equipment labeled. And we need any blood products. We want to match the items that are to be available in the procedure area to the patient. Very important that we mark our site. So you have a left arm and a right arm. You have a left leg and a right leg. let's make sure that we have the right limb. Sometimes you would think that would be obvious if you have a crushed right leg, that the surgery would be on the right leg, but sometimes these surgeries are not obvious. So we need to make sure that our physician is marking the site specifically with the patient if that's possible. Here is a comprehensive surgical checklist. These are a bunch of rules and things to look at before our procedure. Our 3 governing organizations collaborated on this checklist. The left column is completed in the pre-op phase, and the rest are completed in the intra-op phase. Preoperative nurse takes on a multitude of roles, including educator, advocate, and admittance nurse. The nurse's main priority is to complete a preoperative checklist. Each facility's unique checklist ensures that the necessary documentation, administration, assessment, physical preparation, and the educational needs have been completed prior to the patient entering the surgical suite. Now, pay attention, because this checklist is not consent. We will go into consent later. This is a checklist that the nurse will fill out to make sure that everything information-wise has been gathered together and we have it in one place and that it is proper. Consent is different, and we'll talk about that in a moment. Needed patient medical, social, and surgical histories are the key to a successful surgical experience. These questions may be asked during a preoperative workup or upon admission to the surgical facility. As the nurse prepares the patient for surgery, he or she asks a series of detailed questions. Some of the questions may be very personal and at times uncomfortable for the patient to answer. The nurse should remind the patient that this information is very important in providing a safe outcome. It is also important to assure the patient that no judgment will be made on his or her responses and that the information will be used only for medical purposes. As the nurse asks questions pertaining to the patient's medical history, he or she should be taking special note of any conditions that will pose a risk during the surgical experience. A patient's surgical and anesthesia history is very important. We need to know that if they've had previous surgeries, and what are the outcomes? Previous surgeries may have left scar tissue, internal adhesions, or medical implants that need to be considered. The nurse should inquire about the types of surgery, the year the surgery was performed, the indication for surgery, any poor incision healing, and what type of anesthesia was used for each procedure. Any negative responses to anesthesia or wound healing must be taken into consideration while planning the patient's care. Guidelines may be modified for different populations, but typically all patients requiring surgical intervention should have had nothing to eat or drink, otherwise known as NPO, for at least 8 hours prior to the procedure. A patient who has eaten within 8 hours is at risk for aspiration, the introduction of food particles into the lungs through emesis. The preoperative nurse is responsible for documenting the last oral intake. Patients who have special needs, such as those with diabetes, may have altered NPO orders before surgery. Exceptions are sometimes made that allow patients to take essential medications with sips of water prior to the procedure. According to recent guidelines for elective procedures, the patients may be advised to be NPO 6 to 8 hours for solid foods and 2 hours for clear fluids. Anticoagulants, adjusted at least 48 hours prior, and NSAIDs, like aspirin, should be held. There is an increased risk of bleeding. Antihypertensive, these are used on a case-by-case basis, but needs to be communicated to the anesthesia team. Beta blockers should always be given. Insulin is a case-by-case, and glucose must be monitored closely. Less need when NPO, higher need after the stress of surgery. The Patient Self-Determination Act of 1991 grants all patients the right to determine and direct their care in times of medical emergency, the right to create an advance directive. An advance directive defines a patient's wishes should he or she be deemed incompetent to express his or her wishes in a medical emergency. Facilities are required by law to provide the means and guidance to complete an advance directive if desired prior to surgery. With the advance directive, the patient may name a durable medical power of attorney, usually a spouse or adult child who is designated to make all medical decisions should the patient become incompetent. The advance directive also allows the patient to express desires related to organ donation and end-of-life issues. Often advance directives like do not resuscitate need to be suspended during surgery. If a patient has an advance directive that includes a DNR, that information needs to be communicated to the surgical team in order to facilitate the DNR for surgery. We will need to do a physical assessment before any surgery. We need height and weight. Ask yourself, why would that be important? Mostly, again, if we have anesthesia on board, that provider needs to determine fluid needs, medication dosages, antibiotics. All of that is very important. A patient with high BMI may also require larger operating table and recovery beds. Most operating tables have extensions that can meet increased weight requirements. In addition, the OR team may adjust diligence equipment used to transfer the patient. We also need vital signs. Vital signs before one has the surgery is very important to have during the initial assessment. This includes blood pressure, respirations, pulse, temperature, and pulse oximetry. If available, the nurse should compare the admission vital signs with any previous recorded vital notes to see if there's any trends, any major changes. Initial vital signs provide a base to determine the patient's condition during and after the procedure. Increased or decreased heart rate, increased or decreased blood pressure, increased temperature, and decreased oxygen saturation may necessitate a postponement of the procedure if elective. Systems are used to document the patient's baseline. We use this data after surgery to make sure the patient is returning to their prior state. A full head to toe should be done pre-operatively. So we're going to look at the cardiovascular system. In addition to the pulse and blood pressure, the nurse further assesses the patient's cardiovascular health. Peripheral pulses, color, skin turgor, capillary refill, temperature, and edema are important parameters to assess. The nurse also auscultates the heart for rhythm, rate, and murmurs. We're going to look at the respiratory system, including breath, like the rate, the depth, the rhythm, any adventitious sounds such as crackles, rhonchi, or wheezing. We're going to use pulse oximetry to measure oxygen saturation. We should report any clubbing of fingers, which could indicate long-term oxygen deprivation. Make sure that the patient has a clear airway. Patients should be asked to stick out their tongue, breathe with the head tilted up with the chin down, and swallow. This ensures that an airway and any intubation may be safely maintained during the procedure. The anesthesiologist assesses the patient as well during his or her consultation. We're going to look at neurological. Prior to the induction of anesthesia, it's important for the nurse to obtain a baseline neurological evaluation. Assessment of the general cognition and the ability to understand commands is important prior to the induction of general anesthesia. The nurse also assesses the movement, strength, and sensation of the extremities. This is especially important in a patient who will receive some sort of regional block for the procedure. The presence of a preoperative delirium or confusion may delay or postpone the procedure or necessitate admission to the hospital post-operatively. We're also going to assess renal and liver function. The effects of anesthesia and other medications used before, during, and after an operation may be altered if the patient has decreased hepatic or renal clearance. We're going to look at the skin. After surgery, a patient may be still for a long time. They may be more prone to develop skin ulcers. They may also have a large surgical wound that needs to be addressed. So we need to look at their nutrition and their wound healing. What's the skin condition before surgery? That'll help us understand maybe what kind of treatments and wound care we need after surgery. We're going to look at our GI tract, and we want to note typical bowel habits, especially if they're going to be admitted to the hospital. We want to document the presence of normal bowel sounds and any areas of tenderness on the abdomen. We're also going to look at the GU. The nurse should document any devices noted for urinary elimination, such as an indwelling catheter. The nurse should have the patient void before entering the operating suite and note any unusual odor or color of the urine. The patient may wish to discuss any concerns about urination postoperatively. Some patients worry about being able to get to the bathroom without assistance. The nurse should also document any perineal abnormalities on the chart. Very important that when we look at informed consent, that the nurse understands that the role of the surgeon is to obtain consent for the procedure. The surgeon is solely responsible for obtaining consent in the presence of a patient and one witness. Components of the informed consent include consent for the procedure itself, name of the surgeon to perform surgery, reason the intervention will benefit the patient, and alternative options to surgery. Many patients admit to not reading the entire consent before signing. The role of the preoperative nurse is to clarify information and ensure the patient has understanding. Nurses correct common misconceptions and ease concerns of the patient, family members, or support persons. The patient must be cognitively intact to give consent, and a patient who is on a lot of pain medications or sedation legally cannot give consent, but they can also not give consent if they're in a lot of pain and still have questions. So understand, consent is given, informed consent is received by the surgeon, period, end of discussion. The nurse is only there to clarify information that's already been given. If it's new information, then that is something the surgeon is going to have to come back in and give to the patient. You know, for example, they don't understand that afterwards. They're like, hey, I didn't know I was supposed to go and have physical therapy afterwards. Can you tell me, nurse, about physical therapy? You could tell them generically about it, but the actual course of what the physician wants them to do, that needs to be explained by the physician. So we're also going to look at a history and physical. It needs to be completed within 30 days of the surgery date. The H&P should have a review of all body systems. We need to get an anesthesia consent, which will be done by the anesthesiologist. We need to have laboratory and radiological test results. If there is a possibility of blood, like we need a blood transfusion, then we need a blood consent and a consent for blood products. We may also need cardiac clearance. So this may be something where they want to make sure the heart and the lungs are strong enough to have these procedures done. So you could get possibly cardiac and renal systems. Let's make sure that they can handle the anesthesia. So it's standard in a surgery that any patient over the age of 50 has an ECG, and they're usually looking at having cardiac clearance by that cardiologist is needed before they actually can go in and do the procedure. Preoperative, our patient needs some things completed. We need to have our IV access, make sure those are working. We want at least an 18 gauge. That is required usually because of the administration of the blood products if they need to. And keep in mind, that'll be per facility policy. We may need bowel and bladder preparation. It is required that female patients of childbearing age all have a pregnancy test. We need the surgical site preparation. So it's, cleaned or shaved or whatever. We need to make sure our medications are given, that we have our venous prophylaxis ordered. So, after surgery, a person's probably not going to be getting up and moving around a lot. So let's avoid DVTs. Will they have stockings? Will they have the SCDs? Will they, be ambulating? we need to know what the plan is. We also need to address normothermic measurements. It is very typical when someone gets anesthesia that they can either have, some hypothermia. We want to make sure that these guys are comfortable. These surgical suites are often extremely cold. That's done that way so they don't spread diseases and germs, but it's not necessarily the most comfortable for the patient. We also need to have our teaching done. We need to let them know what the experience is going to be like. And, the more information they have, they're typically not as anxious, and they usually have the better ability to communicate any complications. We want to make sure that we're ready to go and that all of these things have been addressed. So in semester 5, you probably learned about how to use an incentive spirometer. We have to teach our patients how to use those. It's very important to prevent pneumonia, and that starts with coughing, deep breathing, teaching the patient how to use the incentive spirometer. You also want to let people know that one of the best things you can do is start early ambulation. I think a lot of folks think, they just had surgery, they need to lay in bed and convalesce, but actually it's better if they start moving around. They get a fuller, deeper breath when they're ambulating. They have full chest expansion, and it helps kind of move fluids around, mucus around, and all that stuff. So let them know that the expectation will be that as soon as possible, they will be ambulating. It's an important rule that anything that could be removed should be removed. We don't want, any electricity traveling on the body. We need to know that, we need to know if a patient has a pacemaker. We need to know, do they have, certain devices, because that could certainly be affected by the surgery. We want to make sure that if they have things like jewelry, contacts, dentures, hearing aids, all of those things are taken out and given to a family member. We want to let everybody know about their implants, and definitely make sure that as we begin the surgical procedure, we're doing our timeout, that right patient, right procedure, and right site, because we want to avoid errors. So after completing the medical record review, pre-op ensures that the first 2 sections of the universal protocol are complete. This includes conducting a pre-procedure verification process addressing missing information or discrepancies before starting the procedure that include confirming the patient's identity and verifying the scheduled procedure is correct and ensuring the surgical site is marked correctly. All of this is to prevent wrong site, wrong procedure, and wrong person. Our timeout portion of the universal protocol is completed intraoperatively. The timeout will be discussed in further detail during the intraoperative lecture. Section is a case study with our patient Maria Gonzalez. She is having a total abdominal hysterectomy. Please work through your questions. Look at this. We will go through this in class. Just make sure that based on the information you have that we've had in this lecture, what do you think the answer would be? So we'll go through these specific answers in class, but take a look and see how well you can do on your own.